and control, I declare this webinar open. Thank you very much. Over to you, Beatrice.
Okay, thank you very much, Dr. Lillian, for those remarks. We straight away go to our presentation. Next slide, kindly. Okay, so as we all understand, today we are going to, our webinar is all about infection prevention and control in healthcare settings. The webinar will be driven by 3 objectives. The first objective is understanding the burden and dynamics of healthcare-associated infections. The second objective is implementing and sustaining best practices in infection prevention and control. And the third objective is antimicrobial stewardship and behavior change for improved IPC compliance. Next. So the 3 objectives will be driven by 3 speakers. And our first speaker is Martha Mbewa Mwelwa. Martha will be taking us through understanding the burden and dynamics of healthcare-associated infections. Martha is a seasoned nursing educator, researcher, and consultant with over 30 years of experience in clinical practice. And she's also the current, she serves as the Dean, Assistant Dean, Research at the University of Zambia's School of Nursing, where she also chairs the Professional and Skills Development Committee, and she also coordinates the medical, surgical, and emergency and trauma nursing. Martha is also the General Secretary of the Perioperative Nurses Association of Zambia and also ECSACONM Ambassador for Zambia, playing a vital role in advancing nursing standards nationally and regionally. So Martha is also pursuing a PhD in nursing at the University of Zambia and undertaking advanced training in cardiac nursing in Birmingham City University in the UK. And she has also published widely and also presented widely both regionally and internationally, earning herself a recognition as a committed leader in nursing education, professional development, and evidence-based practice. Welcome, Martha. Our second objective will be driven by Dr. Anne Asiko Okanga. Dr. Anne will be taking us through implementing and sustaining best practices in infection prevention and control. Dr. Anne is a distinguished nurse educator and researcher with over 20 years of experience in nursing and reproductive health and community engagement in Kenya. She holds a PhD in nursing from Masinde Muliro University, where her research explored mentorship, social adjustment, and peer influence among university students. Currently, she serves as the chair of the Department of Nursing at Kaimosi Friends University, where she leads initiatives in youth mentorship, cancer screening, and reproductive health, with a strong focus on tackling social-cultural systemic barriers, such as teenage pregnancy and substance abuse. Anne played a key role in strengthening infection prevention and control during the COVID-19 pandemic and has integrated IPC into nursing education. Dr. Anne also oversees clinical placement quality, serves as a quality management system auditor, and advocates for safe, inclusive learning environments while advocating equitable healthcare across Sub-Saharan Africa. Welcome, Dr. Anne. Our third objective, which is antimicrobial stewardship and behavior change for improved IPC compliance, will be driven by Dr. Evelyn Wesangula. Evelyn is a pharmacist with a master's in tropical and infectious diseases and she's currently pursuing a doctorate in business administration. She works with the East Central and Southern African Health Community in Arusha, Tanzania, as a senior AMR control specialist, leading regional and microbial resistance and infection prevention and control initiatives. With over 15 years of experience in health systems strengthening and infectious disease control, she has been a strong advocate for antimicrobial resistant containment through a One Health approach. As Kenya's former national and microbial resistant focal point, she also spearheaded the country's first antimicrobial resistant national action plan and established a pioneering multi-sectoral coordinating committee. Evelyn has collaborated with WHO, FO, among other strong bodies and other partners to shape antimicrobial strategies, surveillance, and governance. He also serves on several technical and advisory boards and is dedicated to mentorship, capacity building, and inspiring action against antimicrobial across Africa and beyond. So welcome, Dr. Anne. So as it was said earlier, all questions, we shall have a question and answer session. And if you have a burning question that you feel maybe you might forget, you can put it, you can post it on the chat. So let us have our first presenter by Martha Bewa, taking us through the burden and dynamics of healthcare associated infections. Welcome, Martha.
Thank you so much, moderator. Thank you for the rightly mentioned. I'm going to take you through the burdens and dynamics of healthcare-associated infections, or abbreviated as HAIs, and why they matter so much for patient safety, cost, and antimicrobial resistance. So that is the outline of my presentation. Basically, I'll look at the definition of the hospital-associated infections, scope, and epidemiology. I'll also look at the risk factors and transmission, the implications of these hospital-acquired infections, basically on clinical, economic, and social aspects. And then I'm going to give you the key messages and the strategies that would help to curb this problem and draw the conclusions and recommendations. So, these hospital-acquired infections, WHO has defined them as infections that appear after 48 hours after admission into a hospital facility. And normally, these infections are not present, neither are they incubating at the time of admission. They can occur in hospitals, nursing homes, clinics, or anywhere in long-term facilities where care is given to patients, like hospices. And mostly the sources of these hospital-acquired infections include the patient flora, the staff, the environment, and the devices. We're going to look at them more as we progress in the presentation. The scope and epidemiology. In high-income countries, it is reported that about 7% of patients acquire hospital-acquired infections, while in low and middle-income countries, the percentage is double, 15%. Europe reports over 4.3 million cases annually. However, our friends in the United States have shown progress in reducing the central line associated bloodstream infections, and also a considerable reduction of catheter associated urinary tract infection, and also the methicillin resistant staphylococcal infections, but they still struggle with surgical site infections. A meta-analysis from the 2024 estimates that in the sub-Sahara Africa, about 12.9% of hospital-acquired infections are prevalent, especially in ICUs and neonatal units. So we can see that this burden is really, really big. I'll also give an example of Zambia. A spotlight check reported that the burden of hospital-acquired infections in Zambia is huge because over 242,000 hospital-acquired infections were reported in 2022, with more than 25,000 deaths. And the economic toll this has brought on the Zambian economy is equivalent to 674 million, which accumulates to about 2.3% of the GDP. This is a very, very huge loss. We are also told in Zambia that there's high antibiotic use with cephalosporin, a WHO watch drug, which is used in most 36% of cases. And this has led to a lot of resistance. We are seeing a lot of patients being resistant to a number of antibiotics. And in response to this, Zambia has launched a national infection prevention control strategic plan and the antimicrobial stewardship initiative. And this was launched recently in June. So Zambia is in the sub-Sahara region, meaning that a similar picture may be occurring in the countries around the sub-Sahara region. Are you able to get me?
Yes, we can hear you, Martha.
Yes, but
Yes,
we can't
we can
see the
hear you.
screen. Are you
Okay.
presenting your, is the presentation being beamed? Because we can't see it.
Okay.
Yes, we can see it.
Yeah, we can see
the
the screen. We
presentation.
can see presentation.
Yeah,
Oh, we can't. In Malawi, I can't see it.
Probably it's your device it has a challenge, but the presentation is clear.
Okay.
I can see it.
See it.
Okay. I'll maybe try to reboot.
No, you can proceed. Since
see
it's the majority,
presentation.
the majority can see it. That's okay.
Okay, let's move on. So, after seeing this spotlight in Zambia, let us look at the risk factors and transmission pathways of these hospital-acquired infections. I can't see the next slide. All right, thank you so much. So most the risk factors include, or would say they exist at multiple levels. They'll start with the patient themselves, and these patients, those that have we are getting some feedback. Can some people mute their mics?
Secretariat, kindly Secretariat, let us mute.
Okay, no problem.
Okay. So we are looking at the risk factors for hospital-acquired infections, and we are saying that they exist at multiple levels. And centered to these is the patients themselves. So patients' age, or maybe they are those that are immunocompromised, they are more vulnerable to acquiring hospital-acquired infections. The other level looks at procedures like insertion of central lines and prolonged stays in the hospital also raises the risk of acquiring the hospital-acquired infections. Also, the system challenges like overcrowding, weak infection prevention control, and poor surveillance compound the problem. And when the system is weak, I've seen people moving with personal protective equipment. For example, nurses would move with aprons from the hospital, they go to the market, buy fritters, come back to the ward, and they are in the infectious ward. So transmission occurs via direct contact with droplets, or it can be via the air as airborne particles, or transmission can occur via food, water, and at times or rarely by vectors. We've seen in some hospitals where there are a lot of rats, maybe cockroaches, all these may risk transmission of these hospital-acquired infections. So what is the economic, clinical, and social implications of these hospital-acquired infections? The implications are many. If somebody acquires a hospital-acquired infection, it will cause prolonged hospital stay. And some of them, they come in very critical conditions such that they require ICU admissions. And up to 10% mortality. A lot of people die because of these hospital-acquired infections. And globally, the economic impact is billions annually. More worse in the low and middle income countries, where about $500 per episode is spent. And as in Zambia, we've already been told that approximately 2.3% of the GDP with huge cost to families is lost. Apart from that, the social toll includes stigma, loss of wages, caregiver stress, and erosion of trust in the hospital system. Because even me, I cannot go back to a facility where when I go, I come back with another infection. So people lose trust in the hospital or in the healthcare system. So looking at these serious implications of hospital-acquired infections, what are the key messages? Okay, so we are saying that these hospital-acquired infections are preventable. They are very, very much preventable. And the literature reveals that 70% of these are preventable. And effective surveillance and reliable data drive the interventions. Preventing hospital-acquired infections not only saves lives, but also reduces the cost and burdens in the health services. What then are the strategies to help to reduce these hospital-acquired infections? There are a number of strategies that are included, but I will not go into details because someone is going to talk about this. Briefly, I would say we need to strengthen infection prevention control programs, and these strategies, they work globally, and they are also very much essential in the sub-Saharan region, and Zambia in particular, or any other country that is in the region. We need adequate staffing and training, because I mentioned already about strengthening the infection prevention program. We need functional surveillance systems that will help to identify the areas or the loopholes where infection prevention is weak. And then we need antimicrobial stewardship to keep the resistance. In Zambia, we've put a control to say no antibiotic should be sold without a prescription. It shouldn't be sold over the counter. And then engaging the public in the awareness, because people do not know. Sometimes they just start coughing and they go and get their azithromycin, the cough will go. We need to engage the public to be aware of the consequences of taking drugs over the counter, more especially antibiotics. So in conclusion, we are told that hospital-acquired infections are preventable, but these are very, very common in low and middle-income countries. Strong infection prevention control programs reduces the harm, the cost, and helps to contain the antimicrobial resistance. So priorities should be given to high-risk areas such as ICU, neonatal units, operating theaters, and long-term care facilities where there's a possibility of getting these hospital-acquired infections. Furthermore, I would recommend that multimodal infection prevention control programs should be implemented. Adequate staffing, investment in WASH meaning water sanitation and hygiene, then robust surveillance, stewardship integration, and patient-family engagement. For the Sub-Saharan Africa and Zambia inclusive, the immediate focus should be on WASH and the antimicrobial stewardship integration. Thank you so much for your attention. In case you'd like to get more information on the information that I've given, these are some of the references that I used. Thank you so much, moderator.
Wow.
That is the end of my presentation.
That was powerful, Martha. Thank you very much for such a wonderful presentation. Just to make some summary, you talked so well. You are looking at the burden and the epidemiology of these hospital-associated infections, and it has come out clearly that the burden is high, where we have almost 7% in high-income countries, but for us in the Sub-Saharan Africa, it is even double. You have gone through the high risks, high risk factors, which included age and immunosuppression, among others, and even you have gone through the transmission pathways. You have gone through the economical and clinical social implications of these hospital-associated infections. But the beauty is all these infections are preventable. And how do we prevent? You have given us some strategies, which included strengthening IPC programs and even adequate staffing. So these hospital-acquired infections are common, but they are preventable. The only thing that we should all know as healthcare providers is that anytime you walk in that facility, whether as a patient, as a worker, or as even a caregiver, you have a 14% rate of being infected. And therefore, we just need to take infection prevention and control into consideration and take them seriously. Thank you very much, Martha. Now, as I said earlier, The questions can keep coming. They'll be posted on our chat, and the rest will also come during question and answer session. However, Martha, before you leave the floor, I have some 2 questions for you kindly. And the first question is, based on your experience, what low-cost interventions have you or have shown the most promise in reducing these hospital-acquired or associated infections? From your experience, what low-cost interventions have shown the most promise of reducing these infections we are talking about? The second question is, how can data from hospital-acquired infections surveillance be used to drive policy and practice change?
Thank you so much, my moderator. Indeed, there are a number of evidence-based initiatives that we can use to prevent hospital-acquired infection. And we are all aware that in the hospital, the most basic way of infection prevention is hand hygiene. So as health workers or even caregivers, we must be aware of hand hygiene, simple hand hygiene, or you can either use soap, you can either use alcohol, or WHO has given us the 5 moments of hand washing. And then also the other things that I've seen working adherence care for those patients with the central lines, urinary catheters, those that are on the ventilators. There are care bundles that have been implemented. In ICU, we have what we call ventilator care bundles to prevent VAP, the ventilator-associated pneumonia, where you do simple things like oral care, bed elevation, and all that. Also, the environmental hygiene, frequent cleaning, environment. But they say knowledge is power, and this knowledge can be transferred to people through training and continuous infection prevention control education to all cadres that are working in the hospital. And we said also engaging the community via mass media, social media, we can communicate to them. And the leadership is also a good strategy that I've seen working. Good leaders who enforce the rules and laws. Okay. So the second question you asked about the surveillance, how can it influence policy and whatever. So surveillance system just talks about gathering information on what is happening, how serious the problems could be, where the most frequent infections occur in the hospital. So this would feed, or the surveillance data would quantify the burden and also helps to identify the hotspots and track the resistance, which type of antibiotics or which types of antimicrobial elements are the mostly resistant one. And also it will show the economic cases. So meaning that this surveillance data that we may have can be reported to the authorities, and they'll feed in now to develop guidelines on how best we can set these interventions and help to curb or maybe develop measures to specific target the problems. Or it will also enable benchmarking and accountability. Furthermore, the surveillance data will help in the I think it will help in the resource allocation. Thank you so much. I hope I've answered your question.
Yeah. Yeah, the most interesting one is the simple intervention that can help in IPC, hand washing with soap and water, which we can all practice. Thank you very much. So let us welcome our next presenter, Dr. Ann, to take us through our second objective. Dr. Ann, welcome.
Thank you so much, Beatrice, for giving me this opportunity to share my presentation to the healthcare fraternity and all across board. Well, I'll be presenting on implementing and sustaining best practices in infection prevention and control, that is the IPC. So before we talk about implementing and sustaining best practices, we actually need to give us better understanding or an understanding. What is this? And for us to talk of IPC, it must be systemic approach of evidence-based practices and guidelines in preventing the healthcare-associated infections. And as we do this, it helps us in a prevention of infections or protection of both the patients, the healthcare workers from any harm that could have occurred as a result of finding themselves in the healthcare setting. So adherence to infection prevention and control practices is essential in providing safe and high quality patient care across healthcare settings where healthcare is delivered. What are the practical approaches for hand hygiene, sterilization, and environmental cleaning? When we talk about this trio, the hand hygiene, sterilization, and environmental cleaning, these are the basic components of IPC. In every healthcare settings, once you address hand hygiene, you address sterilization or sterilization aspects, and then environmental cleaning, then you are able to achieve infection prevention and control across board in healthcare. So we look at hand hygiene essentials. And when we are looking at hand hygiene essentials, we look at what is key about this. And Martha has shared very well about the 5 moments of hand hygiene, which is one of the key things. But as we think about that 5 moments of hand hygiene, what is key about this hand hygiene? Is it just normal washing, or there must be a way as healthcare workers we have to adopt so that when we say we are minimizing infection, it is indeed true that the practice that we are putting in place is able to minimize. So we are talking of washing hands with water for at least 20 seconds. We are talking of using of alcohol, standard percentage. That should be very clear. Standard percentage. So there must be an approved percentage in the country, and recommendations basing on the WHO standards of the alcohol-based sanitizers when we are supposed to use that, and also where we are using soap and water. Where we are using soap and water, when there is no soap and water, then that is when we are thinking of the alcohol-based sanitizers. Then the second approach is when we are using sterilization methods. And we all understand that for us to participate in sterilization methods, we come from a low and middle income countries. And these low and middle income countries are faced with challenges, and most of those challenges are financial challenges. So the gold standard is sterilization using steam or autoclaving. But we discover that we may not be able to achieve that in every aspect. One, because it may be as a result of the kind of equipment or instruments we are processing for sterilization. And so that may make us to use other heat-sensitive tools. Examples of those are ethylene and oxide and hydrogen peroxides, using the chlorine coming in different strengths for different purposes. And so even when we are using chlorine, remember, it may not give us that sterilization aspect, but it will provide us the level of high-level disinfection. We must stick to the protocols that are laid of preparing equipment before they are prepared using the chlorine, and even after being used in or being processed through chlorine, what next, so that these instruments can be comfortably said that they are safe for use. And then there is the use of chemical and biological indicators for validation. That is this instrument clean? Can anybody accessing it say that it is safe for use? So that must be very clear, so that it is not just a matter of, was this instrument put into sterilization, but it comes out, the color codes have not changed, and somebody can still pick them for use. So all that must be adhered to for us to ensure better sterilization.
And they selected probably more so for milk production as well as industrial production.
Next, please.
Paleogeneticists will look at Colorado on the mutation, but in a sense.
Kindly mute. Kindly mute.
Next slide, please. So the next approach is where we are dealing with the environmental cleaning practices, because we know our health sector is an environment that we are interacting with the different levels of microorganisms. So there must be standard environmental cleaning practices that will ensure that all our patients, all the caregivers, and the healthcare providers are safe while in this environment. And so what do? We have to ensure that there is division of cleaning, which reduces surface-based transmission of pathogens. Where action more and where is less attention to be given. For example, if you are in an outpatient setting and you are in maybe an inpatient setting, what is standard for outpatient that must be adhered to has to be applied by the people in that place to ensure that there is reduction of surface-based transmission. There is need for us to prioritize the high-touch surfaces, and these are areas like those where most of the time you'll find, for example, the bed rails. The patients will hold them. The healthcare providers will have contact with them. So there is must be a protocol in place that ensures that there is frequent safe preparation of these surfaces so that they can be safer for anybody that is coming in contact with them. Then the use of approved disinfectants, as well as using structured cleaning schedules and staff training to ensure that it is known that at this point, this is the time it is supposed to be done, the cleaning has been done, this is how it has been done by so and so, so that it is easier for us to follow up and ensure that everything is done as required. Then the next approach is, or strategy, is where you combine, and this is integrated infection control strategy and environmental cleaning knowing that all these three-pronged approaches are able to give us a safer environment for our patients to recuperate, in that when they come to the hospital, they will not walk out when they have picked infections from these areas. Then there is need for us to ensure consistency and accountability across all the teams. Whoever is responsible for that particular activity, it should be done when it is supposed to be done and how it is supposed to be done. And somebody should be able to check and say, yes, it was done the right way. Then reinforce the practices with regular audits and feedback. When we don't have audits, when we don't have feedback, not know where we are having challenges, where we are weakening the system. And so there is that need for every healthcare organization or level to have those feedback will provide effort environment for them. Next slide, please. Care, regardless of the patient, whether they are suspected or confirmed infectious state, and apply to all settings where healthcare is delivered. So it doesn't matter whether it is a low income or middle income or high income countries. There are things that must just be done for us to have a safing of the three that we have talked about. We are saying we must have good hand hygiene, good environmental cleaning and disinfection, injection and medication safety. We are emphasizing antimicrobial use so that we are not just picking anytime antibiotics for us to use, but there is a reason why that antibiotic has to be given. The dosage must be adhered to, and everything that ensures that it is going to ensure the safety of the client and the safety of the prosperity of the healthcare without further introducing resistances in the system. Then we need to have risk assessment with use of appropriate personal protective equipment, whereby we understand where there are risks, know this is a risk, and what is supposed to be done for this particular risk. Then minimize potential exposures, where there is chances of exposure, minimize as much as possible. Next. Next slide, please. To adhere to transmission-based precautions, and in the transmission
We have lost you, Anne.
documented patients with documented or suspected diagnosis where contact with the patient, their body fluids, and environment presents a substantial transmission risk despite adherence to the standards. We all saw what happened during the time of COVID-19.
Dr. Anne, we have lost you. We have lost you, Dr. Ann. I've lost Dr. Ann. Anybody who can hear her? Or is it her network?
No,
We
I
have
think
lost
we
her
have
too.
lost her.
Yeah, I lost her too.
I think because of our network. It's breaking down.
I think, yes,
Sorry
Julius,
for
you're
that.
saying?
Yeah, she has back.
She's back
She
now.
can proceed.
Okay.
Okay, thank you so much for that. We were talking about the transmission-based precautions, and we are saying that it must be based on what is the risk, despite their normal adherence to the precautions. So that risk must be assessed so that where there is a high risk, adapt transmission-based precautions to the specific healthcare settings, the facility's design characteristics, and the type of the patient interaction to make sure that at this point, every need is addressed to ensure that there is no transmission that is happening just because there was maybe a surge or a new infection or something that was not anticipated at that point. Thank you. Let's move on. The examples like where we have the temporary invasive medical devices for clinical management. And we are saying, for example, in patients who are on long-term treatment, and they're having issues like they're having gadgets like catheters, feeding tubes, ventilators. You must identify the earliest opportunity for safe removal. And where safe removal may not be at that point, then care must be provided so that we are able to reduce chances of continuous infection or reinfection to this particular client, despite the fact that they are having that invasive device, medical device that they have to have for that specific time. So we ensure that healthcare personnel adhere to the recommended insertion and maintenance practices in whichever place that they are functioning at. Next. Now, we cannot achieve IPC without leadership. So every time we think about IPC, we must think about leadership from the top, that is the national level, to the lowest health facility or place where care delivery it should allocate sufficient resources to infection prevention so that we ensure consistent and prompt action. Martha told us about the cost of infection in hospitals. And if we look at that, the economic implications of that, then we will understand why allocating sufficient resources to this activity that is a preventive activity can really save our patients and our healthcare providers from these infections that can occur in hospitals. Then we need to assign individuals with training in IPC to manage the facility's infection prevention program so that they are providing support from a point of understanding, not just any support, but understanding of why and what needs to be done. Then empowering of those managing infection prevention programs to ensure that there is effectiveness. Empower them with the resources, empower them with knowledge. Next. Another role of leadership is education and training of personnel on IPC. We cannot overemphasize on this because there must be provision of job-specific IPC education and training to all healthcare personnel for any task. As long as this person is entering a hospital or a healthcare setting and providing care, there must be job-specific IPC education for them to safely practice. Then train before individuals are allowed to perform their duties. And when gaps are identified, let us provide additional training. Then develop processes so that we can ensure compliance and provide written policies and procedures to ensure that there is evidence-based guidelines in place and people can follow them so that when this procedure is now not working, we are able to identify where is the weakness and what can be done. Next. Another role is patient, family, and caregiver education. We understand that healthcare settings are not for patients, for healthcare workers alone. Caregivers will be found there. Patients will be found there. All these provide the three-pronged approach in our IPC, whereby we are saying take care of the healthcare worker, take care of the family and caregiver, take care of the patient, and then the three of us, we are able to break that triad of infection in our hospitals. So they should be provided with appropriate infection prevention education that is relevant to the settings where they are, and in a language that they can comfortably understand and adhere to. Is it hand washing? Is it masking? What is it that is expected of them? So that wherever they are there, they are able to practice that. And this should be for every healthcare worker. Should be able to provide this information with the stewardship of the leadership in the institutions. Next. The other role is performance and monitoring and feedback. There should be need for monitoring of adherence to IP practices and control. We don't just institute the measures and leave them like that. We institute, then we go ahead and monitor and make sure that all the people that need to adhere to IP are adhering to them. Where there is feedback, let us promptly put mechanisms that can make us receive this feedback and work towards meet monitoring personnel. Whoever you want to be, the ones monitoring and ensuring that IP is in place, let them be trained so that when they are going to check, they know exactly what are they checking that are meeting standards and what are the lapses that are in place. Then monitor the incidence of infections that may be related to care provided. Data will be used to make informed decisions based on that. Next. So what do we do? We are saying we need to engage frontline healthcare workers in IPC initiatives to ensure consistency. Who are the frontline healthcare workers? These are the people that every day are in contact with the patients. We must engage them. And for us to engage them, we must foster a culture of safety and collaboration, create a supportive environment that they feel, yes, we are engaged in this, we are involved in this, and when we have a problem, somebody can address the problem. Emphasize that IPC is not about compliance, but ensuring patient and staff safety, that it is for all of us. So all of us must take that initiative and make clear that everybody must play a crucial role, that where there is a weak link in any of us, it can jeopardize the life of any of us. Next. We should publicly acknowledge the good practices that can motivate others. Where something is done well, let us talk about it. Where something is not done well, let us also say about it. Develop incentive programs, address barriers, and routinely supervise peer accountability. Next. We have a case example, and I will refer you to Kasuja et al. 2024, where they did their study on enhancing infection prevention and control through hand hygiene compliance in 6 Ugandan hospitals. And this is a clear case of how IPC can be used to improve health and better patient outcomes in a setting. In conclusion, when we implement IPC, it gives us better outcomes in patients and also in healthcare workers. Thank you.
Thank you very much, Dr. Ann, for that good presentation. Though you had issues with your network, but we understand sometimes some things are beyond our control. So thank you for that. And if I can remember what you told us, you are saying that infection and in infection prevention, we are supposed to implement and sustain best practices. And by doing so, we are protecting ourselves and we are protecting others. How do we do that? We do it through hand hygiene, through effective sterilization and environmental cleaning. We can also integrate all of them and say infection control strategy where we combine all. However, you also said we cannot achieve IPC without leadership. That is a very important point to note for our leaders, so that for us to be successful in whatever we want to do regarding infection prevention, leadership is very key. So thank you very much, Anne. I'll urge our participants to post their questions to the chat box so that we can also add them when that time comes. However, Anne, again, I have 2 questions for you, if you don't mind. And the first question is, what strategies have proven effective for maintaining IPC standards over the long time? What strategies have proven effective for maintaining IPC standards over the long time? Question number 2, how do you recommend engaging frontline healthcare workers in IPC initiative to ensure adherence? How do you recommend? I remember you talked about involving frontline healthcare workers, and I'm asking, how do you recommend engaging these frontline healthcare workers in IPC initiatives to ensure adherence? Kindly, 2 minutes.
Okay, thank you so much, our moderator. And I want to say that as I was working on this presentation was a question-guided presentation. And so we are able to look at this. 1, what strategies have proven effective for maintaining IPC standards over a long time? And we are saying the gold standard, hand hygiene. That is the gold standard, and this can be practiced by everybody. The healthcare worker can do it, the patient can do it, the patient caretaker can do it. So if all of us will embrace hand hygiene, then we will have minimized the infection transmission by a highest percentage. However, we still have other areas that will need to, and that is where we were talking about now the sterilization and equipment processing, where we, as long as we are using this equipment on patients, then there must be adequate processing of this equipment to ensure that they are safe for our patients and also they are safe for us. Then we looked at surface preparation, which is very key, that our surfaces are our constant contact as we interact with our environment. And we have to make sure that those surfaces are safe for us. Then finally, the multi-pronged approach. You use both of them, combine them, and you are having higher levels of infection prevention. How do we recommend engaging frontline healthcare workers? Motivation, number one. Training, number two. Support, number three. And motivation is not only in monetary ways. There are several ways that we can motivate. Recognitions, meeting recognitions, and all that. We can make them to talk about their experiences and how they have been able to achieve whatever they have achieved, so that others can learn from lived experiences. And all that will make us bring frontline healthcare workers to taking the initiative that this is about us and driving the force to IPC. Thank you.
Thank you very much, Anne. I think you've answered us. So let us welcome our third presenter. Our third presenter is Dr. Evelyn. Dr. Evelyn, welcome on board.
Thank you very much, Beatrice. And I really just want to thank the previous speakers for setting a very good tone and background to infection prevention and control, which is very dear to what we do on a day-to-day basis. And I think this is just a build-up, because after all has been said and done, how do we ensure that we are able to change our behavior? Because infection prevention and control is really a practice issue. It is really not theoretical, but it's an everyday practice that can help to change the culture that we all work within to ensure that our patients are safe and we are able to provide quality and safe healthcare services. So if you move to the next slide, as I transition to just behavior change, and really thanking the team for inviting me to speak about this, and just to bridge the previous two presentations, just giving an overview of AMR and IPC, which again has already been given a very good introduction to, but just looking at the connection again between antimicrobial stewardship and infection prevention and control. Why must they move together? And I really love the emphasis that Dr. Anne has given to hand hygiene, has given to the whole process of ensuring that we are able to observe the standard-based precautions, the transmission-based precautions. I think all this over and above everything, as we continue to work, the importance of integration, and he brought all this together. And I just want to emphasize that it will be important to ensure that there's a connection between these two at all times. And then look at some of the behavior change levers. What is it that drives compliance? And throughout the two presentations, we have heard about the importance of hand hygiene compliance. And as we go through this last session of this webinar today, just reflect back on your healthcare facilities. What is the level of hand hygiene compliance where you work? And even as you look at the overall compliance within the healthcare work, among the healthcare workers, what about yourself? Are we able to comply? If yes, what is it that has driven your behaviors to change for the positive? And if no, what is it that drives us not to comply to the set standards? And then I'll just try to look at some of the data-driven processes, because sometimes we have opportunities to use local evidence to drive quick wins and to achieve the kind of goals that we set for ourselves. If you move to the next slide, that really just tries to introduce IPC again and stewardship, looking at infection prevention and control as a practical aspect, not just something that we do because it needs to be done, but again, we are saying it should be an evidence-based approach. And like, again, Dr. Okanga mentioned, if you can just be able to apply hand hygiene, you have the capacity of reducing the transmission of healthcare-associated infections by up to 80%. And this is not just hearsay, but it's evidence-driven. And you're going to be able to prevent harm from avoidable infections in both patients and the health worker. So it's a two-way traffic. And the other thing about infection control, prevention and control, is that it requires constant action. It's not about doing it today and tomorrow we are relaxing. But if it's running water and availability, it needs to be constantly available. If it is hand washing or it is observing the care bundles to prevent healthcare-associated infections, it needs to be a constant. And not just at one level of care. Anytime you have an encounter with a patient or a client, at all levels, we need to have constant action in place. And she also brought in the aspect of leadership. If our policymakers or our facility managers are not aware of the importance of IPC, then we will find that we have challenges in terms of compliance. And what we have had also is that if we are not able to implement our IPC processes, of course, then we can cause harm and ultimately death can result. And it's impossible to talk about quality healthcare delivery if we have poor infection prevention and control processes. And in our parts of the world, we keep emphasizing that this is so important because our health systems are weak. Our hygiene standards, even when you look at our healthcare facilities, are not where we want to be. And if IPC is not implemented appropriately, then of course our patients can get negatively affected by secondary infections. So over to stewardship. So the flip side is if you're not able to prevent and control an infection, then you need to treat it. But how do you treat it? Is a choice of your antimicrobials guided. And that's why now we begin to talk about antimicrobial stewardship. And that's why we say these two must go together. Antimicrobial stewardship is not just one aspect or a one-off. It is also a coherent set of actions. Just like IPC is a set of processes, procedures, guidelines. Stewardship also is a set of actions that promote the responsible use of antimicrobials. And again, it's targeted towards specific purposes and it's multifaceted. It's not just about choosing one antibiotic, but you have policies that need to be followed. And some of these policies are so linked to infection prevention and control. It's also about surveillance because you cannot choose an appropriate antibiotic if you don't know what you're dealing with in terms of the microorganism. So that means the laboratory needs to be active to make sure that we have data on antimicrobial resistance. The pharmacy also needs to be active in surveillance to know what antibiotics are available. And I said earlier that IPC is linked because if you have patients who are infected with a particular microorganism that is associated with healthcare-associated infections, they might require isolation. So these have to actually always go together, and that's why we talk about multifaceted approaches. And again, overall, the program on antimicrobial stewardship supports proper use in terms of selection, dosing, routes of administration, including duration of antimicrobial therapy. If you move to the next slide, we have what we call the WHO IPC core components, and these have been spoken to in the previous presentations. But I just want to summarize the core components so that, again, as we think about behavior change and looking at what facilitates compliance to IPC interventions or antimicrobial stewardship interventions, you have the overall IPC programs. And this can be at a facility level, it can be at a district level, it can also be at a national level. And we know that in our countries, a lot of our programs are centralized and you are guided by national structures. So if the national structure is weak, the facility level interventions might not be strong because they rely a lot on what the national level does. So you have the presence of guidelines, which we have had again. We have the importance of education and training. And when we have asked questions regarding non-compliance, sometimes you have found our colleagues probably don't have the correct knowledge. And when it comes to IPC, and you talk about health workers, you also realize you have support staff that play a very critical role in breaking the chain of transmission as part of the people that are in the continuum of care for patients. So education and training is not just limited to the healthcare providers. that we know have formal training in medical schools, but also our support staff. Are we training them? Are our managers aware? I've already talked about surveillance. And when you have surveillance, at least you can begin to talk about monitoring and auditing. And monitoring and auditing should not just end there. Or the data that is collected in the facilities, do we feed back to the healthcare providers so that they're able to appreciate the challenges and or the successes that they are seeing in implementing the programs? Then we have this whole very important but equally challenging bit in our setup, an enabling environment. We talk about workload. Do we have adequate staff to be able to implement the standards that we want seen? And that also looks at the built environment. And when you look at our healthcare facilities, is the infrastructure right to support the implementation of both IPC and AMS interventions? And again, are the materials that are being used the right ones? And do we have the right equipment in place? So you look at all this and you bring in the aspect of multimodal strategies that the WHO recommends to be able to help us build that culture that we want to see that enables behaviors to shift from negative to positive. And you look at the first bit on the multimodal strategy, talking about the change of the system change. How are we building it? What infrastructure is in place? Are the supplies available? I might want to perform hand hygiene, but when I get to the sink, yes, there's water, there's a good poster, but there's no soap. So is the system enabling my processes? So we look at all these aspects. Number two, you could have the system, but what about the bit on training and education? And training and education is not just for those that are in service, but also those that are coming out of school, so that when they get into their clinical areas, they're able to understand what needs to be done and apply it appropriately. And apart from even coming in, does the facility itself have trainers? So that when you have new staff onboarding, you're able to continue to build capacity. And even for the existing staff, there's always things that are changing every other day. So we need to be able to teach this. We also need to be able to check monitoring and feedback. How are we doing? We said that we wanted to implement you want to implement stewardship interventions. Yes, you want to monitor how the prescribers are shifting, maybe from they're shifting from IV to oral medication. How are you checking? Are you able to monitor? Are you able to monitor compliance to hand hygiene? Are you able to monitor compliance to the surgical care bundles, for example? So if you can monitor, then you are able to identify the challenges, you're able to identify the gaps, and you're able to propose solutions that speak to context. And once you identify the gaps, do we have a mechanism for feeding back to the entire system, including the leadership? When you have these three, then you can begin to also talk about selling what you're doing. Are there reminders, and is there communication that is going out frequently to promote interventions that we are introducing into the healthcare facility? We also talked about cleaning the environment, for example. How are we communicating the best practices in cleaning the environment? How are we communicating the best practices in waste management, for example? And once you're able to set reminders and communicate appropriately, you begin to change a culture by living what you're talking about. So you are not just talking about it, but as a champion, you're actually walking the talk. That way, you have champions that are influencing people in different departments, and people begin to see a culture of change that is driven by data. When you see good health outcomes, then you realize behavior changes, and also the culture in a healthcare facility changes. Let's move to the next slide, please. The next 3 slides are just bringing in some examples from data from a hospital we will call Zuri. And it's important to demonstrate this because without data, it's very hard to convince people to change their behavior. And not global or regional or national data. If you're in a hospital, you need local data. People need to see, I am in the pediatric ward, and we are the ones who have a 23% compliance in hand hygiene. If I compare myself with another ward, then the challenge is real. It is on the ground. It is not up in the air. And you can see this hospital at baseline started with a 23% compliance to hand hygiene. And when they sat down, they did a proper root cause analysis. They identified where their gaps are, and they set their target. The orange line here is the target that the hospital set. They just wanted a 45% compliance to hand hygiene, but you can see in about 6 months, they had already crossed their target and they got to a 50% mark. And you can see they didn't just look at hand hygiene. You want to see what is compliance to hand rub when necessary, or hand washing when it's necessary. How about the missed opportunities? And then there are those who also think that hand gloving actually can replace hand washing. So you're able to monitor a lot of things when you put in a monitoring and auditing process, and you're able to give this feedback to the facility. And this facility actually would stick these outcomes to the wards. They would go to the ward, and the people in the maternity would see that, okay, this is how we are doing compared to the people who are in the male ward, for example. So measurement is important for purposes of knowing whether or not your interventions are actually making sense. And when there's a dip in your graph or in your data or in your compliance, you can come back as a team and ask, why are we not doing well? And that way you begin to see a lot of change. If you move to the next slide, you will see that apart from just looking at hand hygiene, you're also looking at other aspects, like surgical site infections are one of the key healthcare associated infections that we can be able to monitor, and is recommended that you actually monitor. And one of the bit about surgical care bundles is monitoring surgical antibiotic prophylaxis. And that's why I want to bring in the connection between the infection control team and the antimicrobial stewardship team. Anything to do with antibiotics would directly fall under the AMS team. So if your AMS team and your IPC team are not linked, you might not be able to have optimal patient outcomes. But this particular hospital was able to bring together their IPC team and their AMS team. And they had about 145 patients that they were following. And they were able to see how many patients had a record of the time prophylaxis was administered, because this is important for effectiveness of the administered dose. And if you look at that, then you can see even out of the 145, only 73% had a record. So what about the others? So that speaks to documentation. And looking at the time between this, when this particular antibiotic was administered, they were able to see the process. And with this data, they can go back to the team that's preparing patients for surgery and tell them that this, according to the guidelines, this is what we are supposed to do. But without data, it becomes very hard to be able to go back and speak to the teams. If you move to the next slide, you can see that, of course, at the end of the day, the same hospital, they have monitored how they are adhering to their surgical care bundles. I only pulled out the surgical antibiotic prophylaxis, but there are others that are monitored as well. But at the end of the day, the outcome is what we are interested in. Are our patients developing surgical site infections? And you can see out of the patients that were being followed, 26 of them developed surgical site infections. And you can see from Dr. Ann's presentation again, and Martha's as well, we are right when we say that in our low and middle income countries, the rates of HAI are actually higher, much higher than those that are being recorded in the other high income countries. So you can see, you will not know unless you begin to monitor. And when you monitor and go back to the team, you can share this with the infection control team. You can share this with the entire clinical team in the hospital, and people begin to see the gaps, and you close the gaps by bringing in interventions that actually would demand a shift in behavior change. If you move to the next slide, then it introduces some of the multimodal components and what you would do, and this is specific for hand hygiene. And I just put this here to show us that even when you have strategies on paper and you have them as guidelines, they are not always complied with by staff. And of course, if we are not able to implement this effectively, then the impact will be so little. You have good guidelines, but less impact. And where there is poor practice, we need a specific drive to optimize the performance of the behavior to improve staff. Application of best practice is key roles of the IPC practitioner. So if you move to the next slide, you'll see some of the behavior change models that have been proposed. One is the COMB that talks about capability, opportunity, and motivation that influence behaviors. Are your staff able to do it? Are you able to do it? Do you have the right knowledge? Do you have the right skill? Are you competent? Capability. If you're not, even if you have a guideline, there'll be a challenge. Is there an opportunity that speaks to the environment? I want to wash my hands. There is no water. I want to perform a hand rub. Alcohol-based hand rub has been out of stock for 6 months. So the opportunity goes, is there motivation? Why am I doing it? When we are clear on why we want to do something, when I know that the life of my patient depends on my action, that is good motivation. And this again is tied in with this other behavior change wheel that talks to multiple other aspects. Apart from the COMB, we've talked about the capability, opportunity, and motivation. We also have other details like the environmental, social, and environmental aspects. We have communication. How do you market your IPC? It needs to be marketable. If you cannot sell it, nobody will adhere. How can you persuade your colleagues if you're a champion, for example? How can you incentivize award to continue being the best in complying to hand hygiene? It can even just be a cake that the team will cut to celebrate their big win after sustaining the highest compliance to hand hygiene for 4 months. For example, if you're the ward in charge, incentivize your staff. But if you can't motivate, then there is the place of legislation. And a lot of hospitals are now being sued when patients develop HAIs. Then there's a place of service provision where there's training and enabling environment. And then you're able to also model, and also in the presence of adequate financial or fiscal measures, you have the right environment, you have the right infrastructure, you have the right equipment. These are some of the things that can motivate people to comply to guidelines. So these are just examples of some of the things that can actually help us to motivate ourselves and our colleagues. So they can be physical, it could be social. When I see my colleagues and the consultants are performing what is needed, then other healthcare workers are motivated. It can also be psychological. Some of these things can also be reflective. It can be taking moments just to sit down and reflect on actions, either as a team or as individuals, to drive our capacities to have better behavior at the end of the day. If you move to the next slide, then it tells us that once you begin to apply some of these aspects on behavior change, we get to a point where you have data, you sit back and review your data and identify the barriers and facilitators to interventions that you have proposed. These are just some examples. Some of them can be related to the environmental context and resources. And this is specific for hand hygiene. We keep talking about hand hygiene because it is one of the single most effective and cheap measure that we can take and really see great results. Some of our colleagues say, I have too many patients. I don't have time to wash hands in between every patient. Okay, they will also look at the workload. I have 24 patients. Can I wait to administer this medicine at the right time? That is workload related. And of course, the environmental controls. I want to cohort my patients. Do I have an isolation room? If it's not there, we are stuck in the same particular aspect. So these barriers can be significant in terms of stopping behavior change, and people just continue doing what they have been doing for a very long time. Then you can have social facilitators, like leadership can be a great facilitator once your leadership buys into your process and when they understand the consequences to themselves and to others. And I keep hoping that we actually learned from COVID and we are able to take on all the lessons on infection control, not just for ourselves, but for others as well. The next slide. So some of these are important aspects that can help you to shift behavior in a positive dimension. Begin with the why. When people understand why they are doing something, I think buying is better. Persuade colleagues if you are a champion, and also be clear on expectations. And having small expectations helps, because frustration comes when expectations and you're not able to meet them. So don't oversell the outcomes. Start small. Have meetings that are skilled and people appreciate the discussions. Also, be aware of resistors and constipators. There are those colleagues who will definitely not like what you're introducing. They will not like your policing. and they will try to constipate the process. So be aware of these ones and see how you can be able to take them out for a cup of tea and convince them to join your camp. And again, some of those people who deviate from the norm can be your change agents once they buy into your vision. And of course, we've talked about leadership. Obtain their commitment and support. Keep them focused on the goal, and keep your teams engaged always and resilient. And again, I've talked about the power of small wins. If you have scored, celebrate. That keeps the teams going. And again, sell the work at the podium. Talk about your work, the success of your interventions to your leadership and to your management teams at any given time. And again, because every project has a story to tell, don't be quiet when you succeed, and even talk about the times that we have not been able to be successful. Some of these things can impact behavior change in a positive way. They are simple and they are actually doable. So my last slide is actually just trying to emphasize that for us to be successful in implementing our IPC and stewardship interventions, we really need to change our behavior and attitudes towards this. And until we understand, it becomes very difficult. And again, just to emphasize, like my colleagues have said in the previous presentation, we don't have a single best approach. It has to be multifaceted from different angles. Our strategies are multi-pronged with various levels of stakeholder engagement. I talked about support staff. We've talked about leadership. We've talked about policy makers. We've talked about multi-speciality. It's not just about the nurse. We need every discipline on board. A lot of education and training, a lot of assessment and feedback to ensure that there's accountability. When you have accountability, there'll be behavioral nudges and people begin to shift their behavior and the culture also changes. Evaluate what to change. You cannot change everything at the same time and why you're doing it at that particular time. And you can also just take advantage of these behavior change theories to explore your current barriers